So moving on to the next section, I would like to invite the chairpersons for the session 5. Dr. Kishan Srikanth Juva is a consultant pulmonologist in KIMS Hospital, Secunderabad. Dr. Chetan Rao is a consultant interventional pulmonologist, Yashoda Hospitals, Hyderabad. Dr. Vishweshwaran, consultant interventional pulmonologist, Yashoda Hospital, Hyderabad.
I'll now introduce Dr. Kedar Hebre sir. He's a consultant pulmonologist from Narayana Health City, Bangalore, and he'll be today talking on approach to pleural effusions. Sir, please.
Thank you chairpersons for the kind introduction, and of course the AIG team led by Gela for inviting me. Normally I usually don't talk on pleural effusions, but Gela has given me a very difficult task. And probably like many of you here in the audience, going back and reading the basics of pulmonology is what I really did myself too, being an interventional pulmonologist, and it helped me revise a lot of my basic concepts. And I hope I'll try to keep it very basic, very minimal, and give you some pointers on what you could do. So before I proceed to my presentation, there are no conflicts of interest I have to declare. And I am going to be sticking to the ABC of pleural effusion, that is the hardcore basics. Let me also tell you that I won't be talking anything on malignant pleural effusions because my good colleague Dr. Nagarjun Mathur is going to be talking about it in a morning session tomorrow. Okay, so what are we going to do today? I'm going to introduce the topic. I'm going to talk about very basics of pleural physiology. We'll discuss exudates and transudates. What is predictable? We'll look at the existing diagnostic algorithm for it. And what do we do in the evaluation of pleural effusions when we are stuck, and we look at the gradually shifting paradigms, and when we are stuck, what are we going to do? What are the myths and pearls? Many of you are postgraduates. I've put up my email address there. It's kedarhibari@gmail.com. There's no need to take any photographs. I'm quite happy to email all the slides to you. So don't bother about wasting your time taking photographs. Again, I repeat, it's kedarhibare@gmail.com. So just write a mail to me for the presentation. I'll share it. Don't worry about it. Okay. So let me introduce the topic. So what is pleural effusion? It is nothing but an abnormal accumulation of fluid within the pleural cavity. It forms because of an imbalance between the formation of the fluid and the absorption of fluid. And of course, there are local and systemic factors which basically cause the pleural effusion to accumulate. So where does pleural fluid really form? It forms not in the visceral pleura, but the parietal pleura, and it gets absorbed in the parietal pleura. But apart from that, of course, the interstitium also can produce pleural fluid, and so does the peritoneum. So there are three areas where pleural fluid formation can happen. But while absorption happens only with the lymphatics, it's important to remember that the lymphatics in the pleura have the ability to absorb 20 times the amount of pleural fluid. So if there is an excess formation, there is a good enough mechanism to drain it. And if despite that, or when the system gets overwhelmed, that's when pleural effusion really accumulates. This is just basically the diagram showing it to you. On the left, you have parietal space. In between, you have the pleural space and then the visceral space. So you can see that there's a lymphatic on the left side. And that's where the fluid gets drained from. And basically what happens between this is that there is a balance of hydrostatic and oncotic pressures which promotes the formation of pleural fluid, and the pressure gradient shows net flow of fluid from the parietal pleura, and that it remains in equilibrium in the visceral pleura, which is really the reason why the pleural physiology goes on happening. So various mechanisms of pleural fluid formation have been elucidated in different kinds of pleural effusion. For example, in heart failure, there's an increased systemic hydrostatic pressure along with a decreased oncotic pressure. A very similar mechanism happens when there is hypoalbuminemia or nephrotic syndrome. While in tuberculosis and pleural metastases, where there is an increased protein, there's increased capillary permeability, which causes the pleural circulation, in the pleural circulation. The lymphatic drainage obstruction happens with mediastinal masses. When there's a trapped lung, you see increased negative pressure in the pleural space. With chylothorax, there's a rupture or compression of the thoracic duct. And when there is a hemothorax, there's basically a vascular rupture. So these are different mechanisms, but what is important to understand is all this just happens within the space, with the parietal pleura, with the visceral pleura and the peritoneum involved, and that's really how the fluid accumulates. So since this is a postgraduate, CME, I was told to keep it very basic. So the clinical examination, as you all know, shows a mediastinal shift to the opposite side. There's decreased VF, there's stony dull on percussion, and of course there are decreased breath sounds. But the next step after this is basically that you do a chest imaging. So once you have a strong clinical suspicion of pleural effusion, you go in for chest imaging. And what do you do in this chest imaging is you do the chest imaging. Either you use the ultrasound of the chest, which every single major guideline across the world now considers it to be the standard practice now. X-rays are no more standard practice in ultrasound, in pleural effusions or in pleural diseases. It's now the ultrasound of the chest. Of course, a little lesser, more, but a better effective, imaging modality than a PA would actually be a lateral decubitus view, and that's because you can even image about 75 to 100 ml of pleural fluid. So that's really something that I wanted to highlight. But once you confirmed the fluid on imaging, the next step is basically to classify it either as an exudate or transudate, and all postgraduates here must be knowing the Lights criteria off their hands. And once you've done that and classified the fluid, your next workup starts, because that's just the beginning of your workup. And then you add additional investigations to get to the bottom of a cause. So that's basically the 3 steps. Now, I'm not going to go into a busy slide. All you need to know is there are many causes of transudates and there are many causes of exudates. But what is important here is the frequent causes and the less frequent causes. So this is basically what you try and suspect clinically when you see patients. The frequent transudates, or the most common transudate that you see, is heart failure, while the most frequent exudates are malignant, parapneumonic and tuberculosis in our settings. But when the diagnosis is elusive, you start thinking about the less frequent causes, and then when the less frequent causes get ruled out, you try to go to the infrequent causes. I don't know how many of you can see this slide very clearly, but this is the current management algorithm for pleural effusion. So I'll take you through this management algorithm a little slowly. So what you basically do is you do a medical history, a clinical examination, and of course a chest X-ray, which act as your first line. Then what you do is, does the clinical picture suggest a transudate? So what you're trying to do is, just with the history and imaging studies, you ask yourself if this is a transudate, and if you think it is a transudate, without having done any further investigation, you treat it. Okay, so I'm re-emphasizing the point. You haven't done thoracentesis yet, but your clinical suspicion of the fluid being a transudate is extremely strong. So you actually treat it and you see if it is resolved. And if it is resolved, that's great. But if it doesn't, that's when you actually proceed to ultrasound guided thoracentesis. So the newer guidelines actually suggest that your clinical suspicion is something that you rely on very strongly, and you treat it first. And if it doesn't really come down, and if this clinical suspicion is that of a transudate from a heart failure, you treat it first and look if it is a transudate. If it comes down, you confirmed your diagnosis clinically. There's nothing much to do but to optimize his heart failure. But let's assume the situation where it doesn't get resolved. And then what you do is you do an ultrasound guided thoracentesis and send the investigations for the first set of biochemical cytological tests and the culture sensitivities. And of course, you apply the Lights criteria and ask yourself if this is a transudate or an exudate. And let's assume that it's a transudate for now and move to the left side of the diagram. And here the most common causes, heart failure, cirrhosis, nephrotic syndrome and trapped lung, are ruled out. Else, what you do is you ask yourself, has the pleural fluid analysis given a diagnosis? And if it hasn't given you a diagnosis yet that it is a transudate, then you proceed to add more investigations to it, depending upon what your clinical suspicion is. If it's a malignancy, you add cytology, pleural fluid biopsy, or a CT scan. If it's a paraneumotic effusion, you want to know if there's septations, if there's loculations, you ask them for a CT scan so that you can probably proceed to do adhesiolysis via thoracoscopy or medical thoracoscopy or rigid thoracoscopy, as the case may be. If the ADA is very high, if it's lymphocytic predominant, all you do is a biopsy with your medical thoracoscopy and then you come out. Heart failure, you may observe, is there both in transudate and exudate. And the reason why that happens is because if you have treated your heart failure initially with diuretics, likely the picture will look like an exudate. And that's again why they have put heart failure as an exudate there and ask you to look for the NT-proBNP here. And then of course you look for any pulmonary embolism and you rule that out with a CT pulmonary angio. You then go on to do additional investigations like CT scans and then consider radiological guided pleural biopsy, as the case may be. So this is basically how you go about it. Again, I'm emphasizing here the two boxes up there. The one on the top is first, when you suspect it, you treat it before you even do your analysis. And this is the reason. That's because the most common, reason why you have a effusion is heart failure, bacterial pneumonia, embolism, malignancy, viral disease, and post-cardiac surgery, in that order. And on the top of the list is heart failure, because pleural effusions come with heart failure so often that it's always important that you click on going ahead with further workup. And of course, once you've done your pleural fluid analysis, there's a lot to gain from it. Okay, and what are the things? The color, the smell, the character of the fluid, all of these things add a little more to your understanding of what you're dealing with. So never ignore seeing your pleural fluid, the character of the fluid, the smell of the pleural fluid, before you proceed to other important investigations. And I'm not going to go through the busy slide, except that, things like, if it's dark green, it's probably biliothorax. If it's brown, it's a long-standing bloody effusion, and so on. So those are something which are very clear. So what I want to leave you with after this particular algorithmic analysis is treat first before tapping if clinical suspicion of the transudate is high, especially if it's heart failure. What is important is a thorough clinical history with systemic examination, and remember to go back to the fluid, look at it, and the characteristics of the fluid tapped are extremely important. Apart from that, of course, your clinical examination should also look for other things: distended neck veins, hemoptysis, hepatosplenomegaly, lymphadenopathy, orthopnea. Basically, all I'm trying to tell you is get back to basics. Pleural effusion management is all about the ABCs: clinical examination, history taking, and so on. And of course, one of the things that we often tend to forget, is taking a history of the drugs that patients take. So if patients are on beta blockers, amiodarone, tryptophan, etc., they're likely to have an effusion secondary to that. So never forget to take your drug history. Let's go a little further. Now, this is the next algorithm I'm coming to, and this is about undiagnosed pleural effusion. So you did your first set and you still don't find a diagnosis. What happens next is you then move on to add more investigations to your bottom, and then you try and get to the bottom of where you are headed. So you reinterrogate and re-explore the patient, review the pleural fluid analysis report and the imaging study, and again ask yourself, is that a transudate? And then if it is a transudate, are there any clinical data suggesting heart failure, pericardial effusions, or hepatic or renal disease, or a trapped lung? And you again proceed accordingly. But if it is not so, consider the rarer causes. And what these rarer causes are: a duropleural fistula, where you look for a beta-2 transferrin; a urinothorax, where you look for the creatinine, protein, and serum levels and look at the ratio. You look for peritoneal dialysis as one of the causes. Then you look for the displacement of central venous catheter, and of course malignant pleural effusions. Okay, and if you think that it's not a transudate and it's an exudate, of course you move on to ultrasonography. And these days the area below ultrasonography is moving more and more towards interventions. So what you basically do is you add in more investigations and you try to get a biopsy. And now, as you know, with the amount of interventions that's happening in the pleural disease, this has become fairly much more easier. You get a histopathological examination, but yes, that may or may not end your dilemma. So always go back, ask for more investigations, suspect things more clinically before you do things. So what's the absolute truth? The absolute truth is this: Assumptions in diagnostic algorithms are that Light's criteria will sort out exudate versus transudate, right? We always think that you just apply the Light's criteria and your job is done. Often enough, that is not the case. Clinical judgment is superior. While clinical judgment may not necessarily be superior and you require investigations to support you, always remember that your history and your clinical examination and your judgment is important, may not always be right. We always also assume, when we're growing up, that patients have only one illness and no confounding factors. So these are our basic assumptions and algorithms and what we go about when we analyze pleural effusions. But the reality is far from above, and the role of advanced diagnostics is extremely important. I've tried to make my presentation interesting by adding in something called myths and pearls, and this is related to the Light's criteria. So one of the myths that we have is Light's criteria remain the best method for separating transudate from exudate. Actually, it's a myth. It's not necessarily. There's a huge scope for misclassification, especially in a patient whom you have already tapped. A transudate can look like an exudate. The sensitivity is 95% to identify exudate, but 25 to 30% of them will get misclassified. And that's something very important to remember. And when such a thing happens, you add something called as the 2-test or the 3-test rule. I'll come to it a little later. Another pearl here is Light's criteria are superior to clinical judgment for discriminating transudates from exudates. This is something that we think that clinical examination and history taking will help, but sometimes application of Light's criteria can just be simple and will tell you if it's it's exudate or transudate. So in a study, they found that clinical judgment actually mislabeled 44% of transudates as exudates, while the Light's criteria mislabeled it only by 25%. So don't always go by your gut. Go with your gut and also use the Light's criteria for doing what best you can. The next pearl is the measurement of NT-proBNP either in the blood or the pleural fluid. It best identifies transudates misclassified by Light's criteria. So do we do NT-proBNPs? And if we have to do NT-proBNPs, would you want to do it in serum or do you want to do it in the pleural fluid? So you all know that 25% of transudates are misclassified and therefore they have additional criteria, which I refer to as the 2-test rule. So you can look at the serum albumin and the pleural fluid ratio to be more than 1.2 grams per deciliter, or serum protein ratio, which is serum protein minus the pleural fluid protein. In some studies, the cutoff is at 3.1 grams per deciliter, while in others it's 2.5. I would go by the 3.1 criteria. And of course, NT-proBNP has also been studied in pleural fluid at different levels, a significant being that of more than 1300 picograms or 1500 as the case may be. All you have to understand is NT-proBNP can be done both in serum or pleural fluid, but it's not necessary that you have to do it always in the pleural fluid. So if you have a patient with a strong suspicion of a heart failure related effusion, you have done the patient's tapping, you find that it's an exudate, you can just do a NT-proBNP, and then if the NT-proBNP is high, you can attribute that pleural effusion to heart failure. It's as simple as that. So the next myth is about time interval between pleural fluid and serum sample collection. So many of us while working, we do the sampling of the pleural fluid now, but the sampling of the serum later. So what is really the ideal time? So there was a very interesting study which looked at two groups. One group with a mean time interval of 1 hour and 12 minutes, the other one almost 28 hours. So after a day. So the pleural fluid sample was collected now and the serum fluid was collected 28 hours later. So that's basically what the discordance is. And then despite there being such a huge gap, the misclassification happens only in 2 cases. Okay, so it's not really necessary that you do the pleural fluid tapping and immediately send the serum. If you have done it within the last 24 hours or after 24 hours of tapping, it's still quite all right. So how do we really go about pleural effusion management? So basically there is a 3 step approach, or a 3-circle approach as I would call it. First, do your pleural fluid analysis. Okay, and there are loads of investigations depending upon your clinical suspicion. Depending upon what you found positive, go ahead and look at the characteristic in terms of color and odor. So and then you get an additional amount of information, and then you can boil down to a most likely diagnosis. So that's really what you can should be your approach, a 3-tier approach to pleural effusion. Let's go to more myths and facts. Okay, and this is about pleural fluid characteristics. So one of the myth that we think that all exudates have clear appearances, in a very interesting study of 766 pleural effusions, only 13% were clear. So don't assume that all pleural effusions which are transudates have clear appearance. Majority of them were straw colored, and they can be bloody in 11% as well, or turbid in 9%. Malignancy is the most common cause of bloody effusions. That's really what we think. You know, as a postgraduate, I always grew with it until I really read this slide. 47% of the bloody effusions are malignant. So there is another 53% which are not. Trauma, pneumonia, post-cardiac injury syndrome, and pulmonary embolism are, of course, other causes of malignant pleural of bloody effusions. But only 11% of malignant pleural effusions are bloody. I'm again repeating it. We all probably think that malignant pleural effusion is equal to a bloody effusion. It is not. Only 11% of them are bloody. Let's go to another interesting area, chylothorax. We all think that chylothorax has milky appearance, and we've all learnt, I learnt chylothorax is equal to milky fluid. But in a study of 61 patients, non-milky chylothoraces were more, were almost 50%, especially when the patients are fasting. So your chylothorax really depends upon your amount of food intake or your fasting state. It can be serous or serosanguinous in 26% and even hemorrhagic in 3%. Right? So don't always assume that a chylothorax is equal to milky appearance. The other thing that we also learn during our postgraduate days is the pleural fluid triglyceride levels less than 110 rules out a chylothorax. It's not necessarily so. While defining the chylothorax, triglyceride level of more than 110 was used as a criteria. But in a study, when all the chylothoraces were looked at, 14% had lower values. In fact, 2 of them had values less than 50. So what is important is lipid content of effusion varies depending upon nutrition. So if you're fasting, your nutritional status all matter when you're diagnosing chylothorax. I've just put 2 management algorithms from a very recent paper in Chest on how to manage chylothorax, and I won't go too much into the details except for you to understand that chylothorax is recurrent non-traumatic chylothorax. That's one algorithm. The other one is a recurrent traumatic chylothorax. So all you need to understand is that there is a duct which can get severed at one of the areas, and whenever it happens, it's either traumatic or non-traumatic, and that's where the problem occurs. And the management of chylothorax really depends upon the output. So how you go about managing chylothorax is the output. Okay, just a couple of minutes. So the next myth is delay in performing biochemical or cytological pleural fluid analysis critically affects the results. So how late is considered too late? So you do the pleural fluid tapping, how much can you delay the analysis? The ideal time is to do it within 4 hours, but you can delay it if you store your pleural fluid with adequate care, either in a EDTA or a heparin vial for 4 degrees for a day. ADA does not change for up to 4 weeks, and cytology doesn't for 2 weeks. Pleural fluid should always be sent for gram stain and culture. It should not always be sent for gram stain and culture unless and until you are suspecting infection, right? Let's get to cytology. Among exudates, pleural fluid differential provides a clue to the origin of the pleural effusion, and that's really a pearl. So when you analyze your fluid, ask them for the breakdown of the cells. If it's neutrophilic, it indicates some diseases. If it's lymphocytic, it indicates something. And if it's eosinophilic, it does indicate something else. Cytological analysis of malignant pleural effusion requires a large volume of pleural fluid. So in my days, when we tapped supposedly malignant pleural effusions, the entire 1.5 liter of fluid drained would be sent to the lab with heparin added. And there were 3 studies which looked at this answer to this question. The sensitivity didn't depend upon the quality of the fluid. There was another study which looked at an incremental yield with increasing volumes, and that was positive. And there was another study where 50 ml didn't increase the diagnostic yield. So what's the truth? So even a small amount is as diagnostically valuable as large amount when you're diagnosing malignant pleural effusion. So don't be under the impression that all the fluid that you tap for malignant pleural effusion requires to be sent for analysis. Pleural effusion secondary to pulmonary embolism may be transudative. The embolisms related to effusions are exudative. I won't go into that exhaustive list, but that's really something that you need to know. And the same thing is with hepatic hydrothorax, where it's actually a transudate and not an exudate, as some may say. So these are the causes for exudates. Cell blocks can be used as an adjunct to increase the yield of smear preparations, and we always wait for the bottom clot formation for analysis. Of course, it is important. It increases the accuracy but does not increase the yield. Okay. Another thing that we also do is repeated thoracentesis in effusions, and that causes eosinophilic effusions. This is something that we found in some studies, but the evidence does not support this conclusion. A chest drain insertion is unnecessary in patients with non-purulent parapneumonic effusions and normal pleural fluid pH levels. Now, we all know that the indication for insertion of pleural a drain is pH less than 7.2 and glucose of less than 60. But what's important is there are additional criteria. If you have positive cultures, it's an indication to insert a tube. If there are loculations or large effusions, all this warrant that you insert tubes. This is the last part where we're talking about ADA, and there's a lot of stuff that's happening about ADA. I've heard people tell ADA is completely unreliable and they now rely on biopsy. But what I'm going to show you is this infographic, which is very important. On the x-axis, you have prevalence, and on the y-axis, you have the percentage. So the positive predictive value, when the prevalence is low, the positive predictive value is on the lower side. What is important is the negative predictive value is very, very high. And you go to the opposite end of the extreme, where the prevalence is extremely high. Okay, the negative predictive value tends to fall down. And this is an infographic that you need to remember when interpreting ADA. So it's important to rule out rather than rule it in, depending upon the prevalence of tuberculosis in your population. Okay, an extremely high ADA in pleural fluid should raise the suspicion of a non-tubercular pleural effusion. And this is an important pearl, because we always assume ADA is equivalent to a TB effusion. It can happen, especially when it's very high in empyema and in lymphoid malignancies. Testing for pleural fluid ADA is easy and inexpensive method. And of course, it's also useful in HIV patients. And on another point, what I would insist on most of you is we completely fail to inoculate the pleural fluid in bedside, and this is something that's very important. So if you are suspecting you want cultures, always get your blood culture bottles bedside and inoculate them immediately, because they are likely to provide you with good result and probably even early result, as in this study where you were able to get pleural fluid diagnosis or cultures at 3.5 weeks when inoculated bedside, rather than when in the lab when it was 4.7. Mesothelin measurements are also known to help us in the diagnosis of mesothelioma, and that's an important biomarker which is coming up in mesothelial diseases. The last couple of slides, negative pleural fluid cytological examination does not rule out malignancy. Now, we always think that it's negative, there's no malignancy. It's not necessarily so, because it all depends on tumor type. If you're dealing with ovarian, breast cancer, you're more likely to get pleural fluid malignant cytology positivity than when it is lymphoma. And of course, remember that there's a sarcomatoid variety of mesothelioma which has the poorest yield. Okay. I'll skip a couple of these slides. Again, this is another important myth, pleural fluid amylase should be requested only if pancreatic disease or esophageal rupture is suspected. Remember that pleural fluid amylase is elevated even in neoplasms and TB. So send this investigation only and only if you're suspecting a pancreatic or an esophageal rupture. Okay. ANA, I'm going to skip it. The last couple of slides. Formation of pleural fluid can sometimes be due to 2 or more concomitant disease in a given patient. This is something that you must not forget. And when there is a bilateral pleural effusion, each with a different cause, the syndrome is known as a Kotrani syndrome, right? And despite extensive workup of the pleural effusions, about 5 to 20% of them will remain elusive. Okay. I'm leaving you with this take-home slide where you have to try and get to a diagnosis with a 3-tier approach. And as a take home, I will say stick to basics always. Myths in pleural diseases are basically because of misinterpreted fluid analysis, and an astute clinical approach supplemented with good amount of investigations and thought will help you aid in the diagnosis of pleural effusion. Thank you, ladies and gentlemen, for the patient hearing. I'd be happy to answer any questions that you may have.
Thank you, sir. That was a wonderful, crisp and evidence-based presentation.
Thank you.
Wonderful presentation, sir.
Thank you.
In the interest of time, just quick question, sir.
Yes.
Which is most common for the benefit of postgraduates. So, after diagnostic thoracentesis, what is the ideal time that it should reach the lab, or is there any special storage conditions for that?
So, I have dealt with that question's answer, saying that the ideal time should be less than 4 hours. So, try and send all your analysis within 4 hours. But just in case that you're not able to send it, please collect your pleural fluid in EDTA or EDTA vials and put it in your refrigerator. And for up to 4 weeks, you can do your cytological analysis. For 2 weeks, your ADA analysis without any problems and with reliable results. Thank you. Thank you so much.